Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome, I'm Dr. Hirsam Khalifa. I'm an emergency consultant, and we are going to talk about the lung ultrasound in this lecture. Actually, the lung ultrasound is very important in the setting of emergency or in critical care situation. As actually, if we are suspecting something like pneumothorax, we would use the lung ultrasound. If we are looking for the pulmonary edema, acute respiratory distress, we are going to use the ultrasound. In case of the patient who is dyspneic and tachycardic and suspecting pulmonary embolism, also in the patient who is with trauma, we are suspecting pneumothorax, or when we are suspecting the pleural effusion, we are going to use the ultrasound. Some cases in the ICU, in the diaphragmatic palsy, also in the consolidation. All of these are applications for the lung ultrasound. Okay, so which probe we are going to use? We are going to use the linear probe. We are going to use the linear probe or the superficial probe in when we are checking the lung, or when we are checking the pleura on both sides. Also, we can use the curvy linear probe or the low frequency or the phased array probe when we are checking in the costophrenic angle, when we want to check something like hemothorax or pleural effusion. So where we will put our probe? Actually, we have some points. We call it as blue protocol. These points are the major points to detect any lung abnormality or any pleural abnormality. We have roughly 4 points. To get these points, we can put our hands as we see in the picture, just below the clavicle. The first point will be between the middle finger and the ring finger, and the next point will be at the middle of the right hand, and after that we draw a line at the lower end of the little finger of the right hand until we reach to the mid-axillary line. So this is the third point, and until we reach to the posterior axillary line, and this is the fourth point. Actually, we use our probe in a vertical plane and with the marker directed toward the head of the patient. We use our probe like this, our marker directed to the head of the patient in the different planes. And after that, we use the convex or the curvilinear probe at the costophrenic angle to detect and exclude pleural effusion and hemothorax. So this is a lung examination, and we are putting our probes for different plane to detect because sometimes you can detect the pneumothorax at a plane when it is higher, because usually the pneumothorax comes upward and you can detect it in the basal part. So this is the importance. You have to put your probe in different places. If you put your probe, for example, in this area, you will detect the pneumothorax. But if you put your probe also in this area, you will detect the pneumothorax. If you put your probe in this area, this is called the lung point, and it is the point that is specific between the normal pleura and the abnormal pleura. It's very sensitive. You will see some part of the pleura is normal moving, and the other part of the pleura is not moving, and it's called the lung point. And if you put your probe after that, you will see a normal pleura. So it's very important to use your probe in different levels to detect any pathology that's found in different levels. So let's talk about the normal lung ultrasound. Actually, when we put the probe, the ultrasound waves comes through the skin and the chest wall until it reaches to the pleural line. It hits the pleural line, and after the pleural line, there is some air after the pleural line. So the ultrasound waves are reflected. It draws the pleural line, which is moving, which is sliding. So this is the normal pleural line. And because there is some air just behind the pleural line, it is repeated in a similar distance. So you could find that the pleural line is repeated in a similar distance, and this is called the A line, and this artifact is called the reverbation artifact. So this is the normal lung ultrasound. So when I am putting my probe in this vertical plane, I could see the rib, and the rib is hyperechoic line, and posterior to it you could find the posterior acoustic shadow, and after that you could find the pleural line, which is sliding and moving hyperechoic line, and below it you could see the A lines, that's the repeated pleural line at the same distance when the lung tissue is normal, when it contains air, and after that you could see the other rib and the posterior acoustic shadow. So this is the normal lung ultrasound, and we call it as a bat sign because it is looks like a bat, okay? So this is the normal lung ultrasound.
Rib 2,
Okay,
in between the ribs, we
let's
have
now
the pleural
talk
interface, the lung.
about the normal lung artifact. In the normal lung, we have the pleura that it is sliding. We have the A lines. We have what is called lung pulse. We will talk about the lung pulse later on. And when we put the M mode, we could see the seashore sign, and we will talk about it. Okay,
Rib 2,
so
in
this is
between
the
the ribs,
normal
we have
pleura. You
the
could see
pleural
that there is
interface. The
a
lung
distal
slides back
pleura
and
and the
forth with that
parietal
pleural
pleura,
interface.
and usually it is
Now,
moving or
as the patient's
interlacing to
rib
each
2, in
other.
between.
When the pleura moves, you could see the movement of the pleura like the ant march line. So this is a normal sliding moving pleura you could see in the ultrasound. So this is normal lung ultrasound, normal lung artifact, reverbation artifact. You could see the pleural line and the A line, repeated lines just below the pleura in the same distance. So when you put the M mode over the lung, you could see that there is in the M mode some oscillation in the M mode, and this oscillation is at the same time of the heartbeat. So when the heart is beating, there is some oscillation occurs in the pleura. You could see it in the M mode, and we call it as the lung pulse. This is very important because it occurs in normal pleura. But if the pleura is not moving, you will not see the oscillation in the lines of the M mode over the pleura, and this would be called that there is no lung pulse in the pleura, which is abnormal. Okay, so when I put my M mode over the pleura, I could see the upper part of the M mode light lines. This is because light lines because the upper part, which is skin, superficial fascia, and subcutaneous muscle, is not moving, and the lower part appears like dots because the lower part, the pleura, and the lower part is moving. So this is called the M mode, the normal seashore sign. So this is the normal sliding pleura. I could see the pleura is sliding. When I put my and I could see the A line. When I put my M mode, I could see the seashore sign, and also we see the oscillation in the M mode, and this is called the lung pulse. So this is the normal lung artifact. Okay, so we have what's called interstitial or alveolar syndrome. Like pulmonary edema, like acute respiratory distress, like contusion, like pneumonia, like fibrosis, like atelectasis. What we could see in the ultrasound in all this artifact, we could see what is called the B line. So what is the B line? Okay, now we knew the A line. The B line, it occurs because the normal structure of the lung is disrupted. We have just air after the pleura, but now we don't have air after the pleura. We may have some sort of consolidation, some sort of edema, some sort of fibrosis. So it starts to draw a longitudinal white hyperechoic line, and it's called the B line. So this is the B line and how it occurs in the lung ultrasound. Okay, according to the B line thickness and according to the B line place where it is found, it's found only in patchy area, or it's found bilateral. You can differentiate between the different disease. For example, if you could see the B lines, which is not thick, which is not found in patchy area, so it may be like the B1 line, and it is because of pneumonia. But if you could see that the B line is thickened and found bilateral and basal, it is usually due to alveolar edema, and it may be due to ground glass on CT scanning. Okay, so this is the difference between acute respiratory distress, which is related to infection, and the pulmonary edema. The pulmonary edema, it is always in the dependent area, but the alveolar, the acute respiratory distress in a patchy area. If there is infection, you will find some thing was called pleural line abnormality. We will see it in the ultrasound. And of course, you see some area of consolidation. And in the infection, usually you find that the left atrial pressure and function is normal. But in the patient who is pulmonary edema patient, when you check the heart, you will find the heart is congested with chronic heart failure. Okay. So this is the, when you find the B lines, you ask yourself if the patient is acute or chronic. If your patient is acute and it is diffuse B lines, so you will think about the acute pulmonary edema. If it is patchy area of consolidation, you would think about the ARDS. If your patient is chronic and you found that it is diffuse B line, so you would think of chronic heart failure. And if it is uneven B line with pleural line abnormality, you would think about interstitial fibrosis. Okay, let's see this ultrasound. What about the heart? The heart, the contractility is not good and the ejection fraction seems to be low. The heart seems to be congested. The lung is wet because we could see the B lines and the IBC is congested and the kidney is normal. So this is a case of the congestive heart failure with lung. So what about this ultrasound? You see that the contractility of the heart is okay. Now the contractility of the heart is okay, but and there is wet lung and there is IBC which is congested and the kidney is not normal. This is renal failure. So we have edema because of the chronic renal failure and the lung is congested because of the renal failure. Okay, so now let's talk about the pneumothorax. What about the pneumothorax? The pneumothorax, there is air that enters between the visceral and the parietal pleura.
Which means a
So
collapsed
this is
lung,
the normal
where
pleura.
air
Now
gets
it's
between the
separated
lung
because
and
of
the
the
chest
air,
wall. That's
so
what a
the pleura is
pneumothorax
not
is.
sliding
Well,
as
now,
normal one. So what would you find in the pneumothorax? At the beginning, you could see that the pleura is not sliding. This is not a sliding pleura. Okay, and after that, there is another causes of the pleura that does not sliding other than a pneumothorax, like fibrosis and other causes. But let's continue. So what we can see in this pleura, we find that the part of the pleura is moved and the other part is not moving. So this is called the lung point and it is highly sensitive for pneumothorax. Okay, if you put the M mode, you would see the barcode sign instead of seashore sign. What is the barcode sign? You would see that there is a lot of lines and no dots like the normal M mode of the pleura. Okay, this is the lung point in the M mode. You could see that the part with the seashore sign and the other part with the barcode sign. Okay, here in the M mode over the pleura, you could see absent lung pulse. There is no oscillation in the M mode related to the pulsation, and this is because there is air that prevents sliding of the visceral and the parietal pleura. Okay, so this is the complete picture of the pneumothorax. What we would see, we would see that the pleura is not sliding. We would see in the other video that there is lung point, and also we see in the lower part that there is no lung pulse and there is the barcode sign of the pneumothorax. Okay, so let's talk about the other indication for the lung ultrasound. The other indication is scanning for pleural effusion and hemothorax. Actually, we can scan at the two costophrenic angles, and we also scan in the upper parts of the lung to check if the pleura or the hemothorax is high arriving to the shoulder. Okay, so we use if we use the linear probe, what we will see? We may see something that is called the quad sign. What is the quad sign? You see between the visceral and the parietal pleura that is separated and like a quadrangular space between both the parietal and visceral pleura when you put your probe in this linear probe in this higher level. Okay, and if you put the M mode, you would see that it will draw like a sinusoid, which is called the sinusoid sign, and all of these are signs of the pleural effusion. Okay, if we put our probe in the curvilinear or the convex probe in the costophrenic angle, what would we see? In the normal person, there is something what is called the mirror image, with the reflection of the liver image to the other side. But when there is hemothorax or pleural effusion, you see that there is an echoic collection and loss of the mirror image, and the spine starts to appear in the below, and this is called the spine sign. Also, in the normal person, there is something that's called the curtain sign. What is the curtain sign? When I am taking my breath, the lung pushing the liver and the kidney down, and this is occurs in the normal person. What if there is some sort of pleural effusion or hemothorax? The lung could not push the liver and the renal, the kidney to the lower side. So this is called loss of curtain sign. So if you found loss of mirror image, spine sign, loss of curtain sign, all of these are signs of the hemothorax and the pleural effusion in our patient. Okay, so what we could see in this image, we could see this an echoic collection, loss of mirror image, spine sign, and loss of curtain sign. All of these are signs of the hemothorax or sign of pleural effusion. Okay, sometimes you could see that there is loculated pleural effusion in our patient. Okay, now let's talk about the lung parenchymal pathology or consolidation. What we could see if there is some consolidation in our patient or infection. We could see sometimes like some signs like, of course, we see the B lines. We see what is called the subpleural consolidation. We see what is called air bronchogram, pleural effusion, and fluid bronchogram. Okay, so this is a patient that he has pleural effusion. And if we look to the lung tissue, we see that the lung tissue is very bright and has a dots of bright or hyperechoic substance. So what is this hyperechoic? Hyperechoic in the lung, it is what is called air bronchogram. It means that there is some consolidation or fluid that entrapped the air inside the alveoli, and so it appears like white dots, and this is called air bronchogram, and it is a sign of consolidation or infection. With the consolidation or infection, we could see that there is some pleural effusion. If we looked at a higher level of the lung to the pleura, what is found below the pleura is some sort of triangular or circular masses. This is what is called the subpleural consolidation, and it is a sign of infection or consolidation. And also you could see the B lines in our patient. Okay, so now we talk about the we will talk about the airway in the other lecture. So just let's go to have a summary of our lung lecture. Now we talk about the lung, and we know how to use the ultrasound. We will use the linear probe and the curvilinear probe. We want to see like what's called pneumothorax. Pneumothorax, what we would see? We would see that the pleura is not sliding. We would see in the M mode that there is a barcode sign. We would see the lung point, which is the point between normal and the abnormal pleura. We could see that there is absent lung pulse. All of these are signs of a pneumothorax. If there is some edema or consolidation in the lung, we will see the B lines. If it is edema, we will see that the B lines is diffuse and bilateral. But if it is infection, we will see the B lines, and we will see what is called the subpleural abnormalities, and it may be accompanied by air bronchogram and pleural effusion. What about the pulmonary embolism? Pulmonary embolism, we will see in the heart that there is what's called the B sign and the McCollin sign in the heart. What about the pleural effusion and the hemothorax? The pleural effusion and the hemothorax, we could see it in the costopharyngeal angle, like loss of mirror image, like a spine sign, like loss of the curtain sign. And we talk about the consolidation and the diaphragmatic pulse. We will talk about it in details in the advanced lung module. Thank you very much, and see you inshallah in next lectures.